The coronavirus. It's spread beyond China.
We have confirmed the first case of Wuhan novel coronavirus patient in Singapore.
Cases have been confirmed across Asia, in the US, and today in France. It's not been designated a pandemic, and it's uncertain whether it has the potential to become one. Yet health experts stress that the scale of the pandemic threat is potentially catastrophic.
It has not yet become a global health emergency. It may yet become one.
A new strain of disease develops. Few, if any, people have immunity. Airborne human-to-human infection enables rapid progress through a population. Globalised travel and urban living puts rocket boosters under its spread. So how well prepared is the world to cope with a pandemic?
Well, epidemics such as this are controlled by standard procedures, which include identification and isolation of those who are infected and sick. The second is to trace all of their contacts. And then the third is to make sure that other means of control can be employed. And sometimes that includes requiring people not to travel or asking them to postpone travel.
This is the latest invention in the fight against SARS.
Scares over SARS in 2003, bird flu in 2006 and swine flu in 2009, and also Ebola and Zika in recent years, have focused policymakers' minds on the need for pandemic preparation. The World Health Organization has established a global influenza surveillance network covering 105 countries as a planetary alert mechanism. But it's one thing knowing what the right procedures are, it's another thing ensuring that they are carried out. Last year, a group called the Global Preparedness Monitoring Board, convened by the WHO and the World Bank, warned of major gaps in our pandemic preparedness. It cited a lack of long-term, holistic, costed resource mobilisation plans. It said that not a single country's preparedness plan had been fully funded. Further, it warned that the WHO itself was underfunded, hindering its ability to provide a global safety net.
There's clearly a gap in funding, and the funding for developing capacity to detect and respond to outbreaks is not being funded by national governments in many developing countries, nor is there complementary funding coming in from development agencies. The World Health Organization is always underfunded. Their budget is very little compared to the responsibilities that they have.
Some experts stress that when it comes to protecting ourselves from pandemics, there's a danger in placing all our focus on short-term emergency responses.
You also need in the long run a sustained focus on building and strengthening healthcare systems at the national level everywhere, but obviously particularly in countries that don't have strong healthcare systems at the moment. So for an international response to be able to effectively support in a crisis situation, you need people on the ground who are well trained to support this response, to know what to do in an emergency situation. But you also need a population who trusts the local health systems, who will actually listen to crisis communications. They will go and seek help in healthcare facilities.
So is our planet prepared for a pandemic? To answer confidently in the affirmative, we may also need to see this hyper-connected world of ours become considerably more equal in terms of access to decent, basic healthcare.
Dr. Tom Inglesby is the director of the Centre for Health Security of the Johns Hopkins Bloomberg School of Public Health. He's an expert in how viruses spread. And Sarah Gilbert is Professor of Vaccinology at Oxford University. And Dr. Inglesby, if we start with you, I understand that you and your team conducted a simulation of a global pandemic of a type of coronavirus and came up with a figure that it could kill 65 million people. I wondered how you reached that figure.
Yes, a few months ago, we put on an exercise in New York City that used a fictional coronavirus and watched it spread over a period of 18 months. And the exercise took place early on in the pandemic, so much earlier than what we might fear later. And we basically studied past coronavirus outbreaks, other pandemics, to try and understand that and try and understand what might happen if a pandemic really played out at a global scale.
I mean, it's interesting because, of course, in reality, we haven't seen anything like that, nothing on that scale, 65 million deaths. I mean, it's hugely high. We do get warnings of these pandemics every few years, but we haven't seen that kind of numbers. Is that down to luck? Are our systems working, or are the models wrong?
No, well, I think if you go back in time, we did see back in 1918, in the last big pandemic influenza, we saw somewhere between 50 and 100 million deaths. Things have gotten a lot better since that time. We have much more modern science and medicine, but we're also much more connected and in some ways more vulnerable. So I think we see a lot of trends that worry us, like the globalization, the movement of people around the world, living closer with animals, antibiotic resistance, megacities. So there are a lot of trends that worry us. We hopefully will never see a day when we have the kind of pandemic we saw in our exercise. But the reason we held that exercise is because we think it's scientifically feasible that something like that could emerge, and we need to prepare for it as a global community.
Professor Gilbert, we hear about vaccines taking a long time and always being sort of lagging behind whatever it is that they're trying to vaccinate against. I mean, are things changing? Is the technology coming down the way that will mean that's different this time and in future?
Yes, things are changing, but it's definitely still a work in progress. So in the past, vaccines were often developed from the disease-causing organisms themselves, and they had to be isolated and then adapted and then tested, and vaccine development would take a long time. Now what we're looking at is new ways of making vaccines, using technology that we can adapt for each individual situation to make a vaccine against a different disease. And because we've used the technology before and we know a lot about it, it enables us to go faster in the vaccine production and the testing and eventually the implementation as well. But it's still not going to be immediate. It's still going to take us several months before we have a vaccine that's ready to go into the first clinical trials. And after that, we have to test if the vaccine not only induces a strong immune response against the pathogen, but if it's actually strong enough to protect. And that testing will take longer, and then production of enough doses of vaccine to vaccinate enough people to control the outbreak will take longer again. So we're probably still, in the best case scenario, looking at about a year before we've got enough doses to make a real impact.
And that's what I was going to ask. I mean, do we have the means to manufacture a vaccine on a kind of pandemic scale?
Well, it depends how many doses we're going to need. If the contact tracing and quarantine and the public health measures are very effective at bringing the outbreak under control, that can dramatically reduce the number of cases. And that's how Ebola outbreaks have been dealt with up until now, when we didn't have a vaccine. But then towards the end of the outbreak, what would tend to happen is that small clusters of cases will keep arising. And if we have a vaccine available at that time, that's very useful for controlling the cases at the end of the outbreak. And it doesn't take very many thousands of doses to achieve that. On the other hand, if we're going to need to vaccinate hundreds, thousands, millions of people, we don't have manufacturing facilities in the UK, certainly, that we can use to make that number of doses. We would need to collaborate internationally to achieve that scale of manufacture.
Dr. Inglesby, in the situation we are in right now, in the situation that China finds itself in, what do you think is the best public health approach? Is it share the message quickly and risk panic? Or is it deal with it in a more low-key way, but risk spread?
Yeah, I think in all cases, the public should be getting all the information that the government has. I think once the public senses that information is being held back, that's when people start losing confidence in a response, confidence in the government that they need to trust to get through this. So I think we need to really give as much information out as possible to the public and to international partners who are also planning their own efforts to try and prevent disease spread in different countries. So I think we should share information. We should work very hard to identify cases with diagnostic testing, isolate people who are sick, I'm worried about larger scale quarantine efforts. Quarantining large cities like this have not happened before in modern times. So I'm worried that's going to get in the way of doing other things that we need to do.
And like what? What other things need doing?
Like finding the patients, getting them to volunteer and come in for testing, and getting them to be isolated in their own homes, or if they're sick enough, isolated in hospital, getting medical care for people who are sick, bringing healthcare workers to the places where people are sick. All that requires movement of people, movement of goods, movement of hospital supplies, and big quarantines can interrupt the movement of those things and also make people afraid.
And Professor Gilbert, I mean, in the UK, there's a lot of unfounded skepticism about vaccines, and I wonder whether that impedes on the work people like you are doing.
I don't think so, really. Once people see a need for a vaccine, once they see a disease that is causing illness and causing deaths, most people are really very interested in receiving the vaccine.
And clinical trials take a long time, and the end process is human testing. Does that process fit in with these new viruses?
It's difficult to do clinical trials when an outbreak's actually happening, but what we do need to do, first of all, is test the vaccines to see if we're getting a good immune response to the vaccine, how many doses of the vaccine we need to give, and the technology that we're working with in Oxford and with our spin-out company, Vaccitech, works very well after a single dose of vaccine, which is important in an outbreak. We then have to try and judge whether we think that would protect people against infection, and then design trials that will actually test if the vaccine is working. We don't want to just go and vaccinate large numbers of people with a vaccine when we don't know if it actually works or not. So designing the trials to get that information while the outbreak's happening is very difficult to do.
Professor Gilbert, Dr. Inglesby, thank you so much for joining us.